at UT Medical School in Houston. I am also involved in taking care of patients with sleep disorders across the spectrum of neurology, particularly those with epilepsy. During the course of this discussion, I was hoping to talk a little bit about sleep, why it's important in general, and particularly so, why is it important in patients with epilepsy? The goals of the discussion will be to understand the sleep cycle overall, what normal sleep looks like, what the phases of sleep are, how the day-night cycle is regulated in human beings, what kinds of sleep disorders exist, how do they relate with epilepsy, and most importantly, what can you do about these? In general, there are many scientific definitions of sleep, but we understand it as a sort of reversible phenomenon, a reversible change in behavior, reversible being the key word, where there is a disengagement from the environment, which means for a certain part of the night or day for individuals, we are not in touch with our environment like we would be if we were awake. Having said that, that is simply an external manifestation. What we now understand about sleep is that it is a complex process, not just that of repair and restore, but many active processes that take place in the brain, particularly when it comes to memory, when it comes to hormonal regulation, and many other factors of human biology. There are external indicators when people are asleep, of course. But again, not everyone sleeps in the same way. The sleep stage distribution varies across individuals, etc. So why sleep, right? And I think this is a question yet unanswered. In general, the theory for several years was that, when it's night, there are several dangers out in the environment, and perhaps a certain amount of inactivity in a safe place kept organisms out of harm's way. Another theory was that of energy conservation, which means when it comes to hunt, gather, etc., there's no point keeping up our energies when we cannot do so, which means during the nighttime. So therefore, why not just conserve energy? These findings were a little bit out of sort with later findings, which came across and talked about the active brain processes, particularly in sleep. And so now there is a push towards thinking that this is more than just rest. And there's a lot of restoration that happens in the brain, coming to repair, rejuvenate immune function, endocrine function, clear toxins perhaps. And the latest theories, a whole fascinating field of literature when it comes to brain plasticity, which means learning, memory, and cognition. So one of the fundamental functions of sleep is memory, which means anything that you learn in the day, or maybe consciously, subconsciously, whatever it may be, is sort of consolidated and processed in the brain at night. This means laying down tracts of memory. Things that you learned in the day that you paid attention to are now put into sort of a hard drive so that you can recall at a correct moment later in life. Another important function is to forget things that you don't need. Given that we have 5 senses and several other sub-sensory perceptions, there is a lot of unnecessary information for which there's probably not enough hard drive space. So a lot of that is also forgotten during sleep. And our memory processes are just sharpened all along the way. In general, as human beings, we exist in these 3 states. We exist either as wakeful human beings, as those in non-REM sleep or REM sleep, where REM stands for rapid eye movement and NREM is non-rapid eye movement. This refers to the side-to-side movements of the eyes when we are asleep, in REM sleep. When we go to sleep, we typically go from wakefulness to non-REM sleep. And that little intersection that you see there is what we call drowsiness. Slowly, we cycle after about 60 to 90 minutes into REM sleep. There's usually an intersection between those two as well. Most commonly, there is no intersection between wakefulness and REM sleep, which means you don't dream as soon as you fall asleep, except under sleep deprivation or certain other circumstances. When those two intersect, then that disorder is called narcolepsy. The typical sleep cycle looks something like this. we go into what we call drowsiness, also called non-REM stage 1. And then we cycle through 1 to 3. 3 and 4 are now considered one phase called delta sleep. And then this part in the initial 1 hour of the night is probably the most profound state of sleep where we are very hard to arouse. And then we cycle about 4 or 5 times through the night into non-REM and REM cycles. The REM cycles usually get progressively longer towards the early part of the morning. REM sleep, where dreams happen, constitutes usually about 20 to 25% of the night. It is also an age-dependent distribution. And non-REM sleep usually takes up most of the night. As we cycle into longer REM sleep periods during the morning, we also dream more. Our dreams are much more vivid. You tend to remember these dreams much more than you would perhaps maybe during an early cycle of REM. You understand that as the longer you stay awake, the more of a sleep burden you develop. And then somewhere along your biological rhythms, there's a clock that tells you, look, it's time to fall asleep. When that clock sets in, you first go into non-REM, REM, cycle back and forth. And then finally, when it's time to wake up, there is another clock that tells you to wake up. You build up a sleep drive, and that goes on to develop again into another sleep cycle. And you understand this is a day-night human cycle. One of the key findings in sleep medicine was that of the circadian rhythm. We talk about it not just in the context of sleep, but several other things. For example, endocrine function, how insulin levels, for example, change during the day, how steroid levels go up in the morning, preparing you to function, and then go down during the rest of the day. How during a stress response, steroid levels stay up constantly. So circadian rhythms developed to sense light and therefore define day and night are usually centered around sunlight pretty much. But in these days, any other device, for example, that emits light would likely generate a similar circadian stimulus. When our eyes sense light, they send a message to what's called the pineal gland to secrete melatonin. You have all seen melatonin in several shop counters across the, many supplements and so forth. And it is basically a clock, a neurotransmitter clock that tells the rest of the body that it's time to start sleeping. Its most profound stimulus is sunlight. And as we start hunting for food or foraging, whatever you may call it, all of those things also affect melatonin. So for example, late night behaviors could affect melatonin secretion. It's not just the brain that has a circadian clock. The rest of the body, including and pretty much every other system, has its night-day variation. So for example, the kidneys start making less urine when it's time to sleep. You would expect that. The heart rate slows down. The gut slows down as well. The entire biological clock was analyzed, and in fact, this is Nobel Prize winning work. And it talks about how all of us have a certain biological rhythm based on our genetic composition. There are families of night owls, there are families of early morning birds, but a lot of it depends on what your genetic predisposition is. You can change it and alter it to a certain extent, but your temperament remains fairly constant. As we go to sleep, or rather as it's time to go to sleep, we have two counterbalancing forces in the body, one that keeps you awake and one that is trying to tell you it's time to sleep. At around 9 p.m. or so, when melatonin starts getting secreted, depending again on different individuals, we notice that our homeostatic sleep drive is the highest. And then towards the morning, as melatonin secretion goes down, light starts to come up. We move up again out into the day cycle. So really, what all happens when you don't sleep? A lot of things. We know, and we have seen children particularly are prone to effects of sleep deprivation. They get cranky, mood is impaired, people get grumpy, memory is impaired, which means you may not be able to recall certain things, especially short term. And You may also not be able to learn things easily. So paying attention and focusing, and therefore completing tasks, that is compromised as well. And many surveys, particularly those conducted by the National Sleep Foundation, NSF, we have those conducted by CDC that looked at NHA survey, all of those have looked at sleep habits in adults. And in many of them, 1/3 to 1/2 of adults reported that they had daytime sleepiness, which made it hard for them to focus at work. A big concern is safety. There are many, many traffic fatalities that have been related to sleepiness, perhaps even more than driving while intoxicated, for example. Several studies again have looked at the spectrum of daytime sleepiness causing safety accidents, and particularly those on the road. And then there are work-related safety accidents, for example, the air traffic control or nuclear explosions in some cases. What other things happen when you don't sleep, now outside of the brain? There are many hormonal changes, which I talked about briefly. And hormones like steroids, for example, are secreted in a different rhythm when we don't sleep very well. That can accelerate weight gain, deposition of fat in the undesirable zones, and lead to obesity. If you think about it, many people that are sleep deprived tend to have this urge to eat. Many of us do that when we are sleepy to keep ourselves awake because we perceive tiredness, and appetite and food intake go up. The other thing that goes up also is insulin resistance. So there's predisposition to diabetes, for example. Particularly, what do we know about the connection between epilepsy and sleep? We know that epilepsy is actually a fairly common disorder. Depending on which studies you read, about 1 to 2% of the population has a lifetime prevalence of epilepsy. When you look at chronic sleep-wake disorders, the prevalence is much, much higher, somewhere in the range of 4 to 4.5%. So look at that overlap. It is a significant subset. In general, about 1/3 to 1/2 of patients with epilepsy complain of sleep-related issues, which means this could be anywhere between insomnia complaints to excessive daytime sleepiness to sleep apnea. And several patients have seizures almost exclusively in their sleep, so nocturnal seizures, which means that these seizures themselves could disrupt sleep. We also tell many of our patients to come in sleep deprived to EEGs, and we try very hard to capture sleep on a routine EEG. The idea being that sleep deprivation is a powerful provocative factor for seizures. And by catching sleep, we usually increase our yield of finding abnormalities on EEG. In general, the relationship works both ways, which means epilepsy itself, particularly nocturnal seizures, can fragment sleep and impact sleep architecture. Medications that are used for epilepsy, certain anticonvulsants, can actually cause insomnia. So there are some others that can cause excessive daytime sleepiness. And sleep disorders themselves can worsen epilepsy simply because of sleep deprivation and overall quality of life. And on the flip side, if you treat these sleep disorders, which in most cases are easily treated, you can actually improve seizure control in many of our patients. There was a national consensus a few years ago on how much sleep really does an individual need, because the next question is, what do you mean by sleep deprivation? Really, exactly how much sleep does an individual need? Our sleep changes, our sleep cycles and requirements change with age. The general indicator for the general indicator for quality of sleep rather, is how you feel in the day. Excessive fatigue, excessive sleepiness. When you wake up, you feel like you've actually slept. That's usually a very good metric of your own sleep need because it is varied across individuals. Although the consensus is that an adult usually needs about 7 hours of sleep. But again, that's a range and could go between 6 to 8. People that need greater than 9 hours of sleep at night are considered to be excessively sleepy, as a broad rule. You'll also notice on the right side of the screen that there are age-related changes, as I talked about, in sleep requirements. And babies tend to sleep almost half the day or more. As we grow up, look at school-age children. The average need for sleep is between 9 to 11 hours. Not many children actually end up getting that much. Particularly for our children with epilepsy, this is an important factor to remember. We get caught up between extracurricular activities and early morning activities and yada yada, and ultimately the 8-hour sleep duration requirement doesn't apply to children. Teenagers need about 8 to 10 hours of sleep. Again, not many teenagers get that. Moving on, we'll talk a little bit about the International Classification of Sleep Disorders, what kinds there are and what we can do about them. You will see that there is a breakdown between certain kinds of sleep disorders, but the point I'm hoping to make at some time during this discussion is that many things can overlap. For example, insomnia, which is trouble falling asleep or staying asleep, can translate into excessive daytime sleepiness. So the symptoms may vary across the board, and that's why getting a good history and understanding what we're dealing with usually helps us diagnose, even in the clinic itself. Insomnia is basically a disorder where there is a chronic, so it has to last for a few days. It's not simply an acute event. A chronic non-restorative sleep, either in terms of quantity or quality. The usual complaints are trouble either falling asleep or staying asleep. But then there are also individuals who sleep and wake up feeling like they've just not slept. It's an exceedingly common disorder. About 40% of American adults have experienced some sort of insomnia symptom or the other. And 1/4 to 1/3 of those on a more chronic basis. Those with mental health disorders, women, older adults, particularly in those that live by themselves, many of these are at risk for insomnia because in them there's also a perpetual lack of sleep hygiene. So how do you treat an insomnia? It takes time. One of the important things to realize about insomnia is that it typically doesn't arise overnight, and so the treatment is not overnight either. Mainstay of treatment includes medications, but only as a temporary measure. The core of treatment consists of what we call cognitive and behavioral therapy, where we teach patients to learn to fall asleep and stay asleep again, because we think it's a forgotten skill. At some point they were sleeping well and they just somehow got away from that. And so a lot of this rests in the hands of our psychologists, where they help move back from their preconceived notions of sleep. What do you do when you're lying in bed, tossing and turning and you can't sleep? You're looking at your clock, you know you're going to have to wake up at a certain time. You know, if you can't fall asleep, the racing thoughts, tomorrow is going to be a terrible day because I didn't sleep. There's a spectrum of very common behaviors that we can train to unlearn and move away from. There are many over-the-counter formulations that are helpful for sleep. Melatonin is usually a common constituent. There are prescription medications as well, which when used judiciously can help overcome the initial period of insomnia, and then slowly, as patients train themselves to fall asleep and stay asleep, we move back from prescription medications. There are in the market now a certain group of devices that can aid with insomnia as well, that are non-pharmacological and therefore preferred by many patients as well as physicians. One such FDA-approved device is a thermal cooling device that is usually placed on the forehead, and by reducing the temperature is supposed to reduce the speed of thought and therefore help the time it takes for individuals to fall asleep. There is also another device which is supposed to increase the depth of sleep, particularly delta sleep, by using acoustic stimulation. And this may not necessarily help with sleep latency, but it's supposed to help with the feeling of having restorative sleep after having woken up, simply by increasing the depth of sleep. Restless leg syndrome is another fairly common syndrome that we see in individuals, which is usually characterized by this sort of creepy crawly feeling in legs that typically happens at bedtime. Patients have the urge to move their legs constantly, and if they move, it gets better. If they don't, then it comes right back. It is actually eminently treatable. It's considered a neurological movement disorder of sleep. And in many cases, it's actually a women-predominant disease. It can be very well treated with good quality of life and sleep. Narcolepsy is a very underdiagnosed sleep disorder. It is diagnosed in patients who are excessively sleepy despite getting adequate quantities of sleep. In many cases, these patients have what we call involuntary sleep attacks during the day, where they simply fall asleep in the middle of whatever they may be doing in the middle in their daytime. This includes sudden loss of muscle tone, sleep paralysis during their sleep. It's fairly common, however, many individuals take up to 10 to 15 years before being diagnosed. It translates into depression and lack of motivation and many other things simply because of lack of sleep, not to mention particularly motor vehicle accidents. And again, this is treatable when diagnosed. Sleep apnea, another very common disorder. The most common kind of sleep apnea is obstructive apnea, which basically happens because of an obstruction in the upper airway during sleep. And it causes gasping arousals in many people. Many others are not even aware they have it. It's usually a male predominant disorder. In many cases, it's related to obesity, but many individuals that are not obese may also have sleep apnea simply because of the way their anatomy is, their maxilla, mandible, jaw structure, etc. And it causes this episodic reduction in oxygen throughout the night, which puts a strain on the vital organs, particularly the heart and the brain, and is associated with a lot of daytime sleepiness. In patients with epilepsy, this leads to frequent sleep interruptions. Because of this, they're more prone to having seizures in the middle of the night. Also, it causes a strain in general on quality of life, on memory, and so many other factors that are already troubled in patients with epilepsy. How do you diagnose and treat sleep disorders? In many cases, we do perform sleep studies, also called polysomnography. For patients with insomnia, a sleep study may not even be required. If a clinical diagnosis of restless leg syndrome or insomnia can be made in clinic, these can be treated even without a sleep study. The typical sleep study that's performed in a lab measures multiple variables, including brainwave activity, sleep stage distribution, looks at heart rate, body movements, etc. And for the purpose of verifying what may be a very clinically strong suspicion of sleep apnea, we can also use what's called home sleep study or portable sleep study. The use of either home sleep study or polysomnography is a judicious decision that's made in a clinic. But having a home sleep study is, number one, much, much cheaper. Two, allows us to capture sleep in native circumstances. And three, it just minimizes the hassle of coming into a lab, etc. There are certain disorders, for example, circadian rhythms, which we may be able to diagnose using sleep monitoring technology, such as may be found in fitness trackers. The treatment for sleep disorders depends again on the condition. If you're talking about sleep apnea, the gold standard of treatment includes CPAP, or continuous positive airway pressure treatment. There are other devices like BiPAP along similar lines, which may be used. There are devices like a mandible advancement device or a hypoglossal nerve stimulation device, which involves minor surgery, that can be used to treat sleep apnea, although they may not be as effective as CPAP. Behavioral therapy is the cornerstone for treatment of insomnia, and medications for both insomnia and narcolepsy. We have now, over the last 3 to 5 years, a much larger selection of medications that we can use for patients with narcolepsy in what was a very limited field before. So really, what can you do for yourself to promote a healthy sleep and healthy lifestyle? The single most important thing that we tell patients is to maintain a regular bed and wake time schedule, including on the weekends. And it's not as easy as it sounds, particularly when it comes to the weekends. You're allowed maybe an hour or so of leeway here and there. But particularly if you have trouble, if you're not one of those who can fall asleep at the drop of a hat, maintaining a regular bed and wake time schedule will go a long way towards helping you sleep. The other important thing to understand is that sleep is not an isolated phenomenon. Really, it's an extension of everything that we do in the day. So managing daytime thoughts, managing behaviors, managing anxiety, which is present in almost 95% of patients with insomnia, those go a long way again to helping you sleep. Learning to detach and developing a regular bedtime routine will again help you fall asleep sooner. The idea is that if you are one of those individuals who cannot drink a cup of coffee and go to sleep, if you're one of those people who needs a bedtime routine, recognize the importance, engage in a relaxing activity of some sort. Try to maintain your food cycles sort of in comport with your sleep, which means don't eat much closer to bedtime, maybe about 2 to 3 hours before. Try to maintain a reasonably dark environment, a quiet one. Temperature zones somewhere around 65 to 70, again, depending on your preference. And in general, give sleep the importance it deserves. To avoid caffeine, for example, that's another hard thing to do because we don't recognize caffeine that's present in non-coffee foods, chocolate, for example. If you are one of those people, again, that has trouble falling asleep or staying asleep, minimizing caffeine will go a long way. If you exercise, it helps overall in general, but there are varying experiences when it comes to exercise and going to sleep. Some people sleep just fine, particularly if they're exerted heavily from exercise. For others, it raises a lot of the stress neurotransmitters like norepinephrine, which may counter restful sleep. So recognize your own capacity for exercise and in what relationship it is to sleep, and avoid doing it too close to bedtime. Napping too late in the day can also intrude into nocturnal sleep. So in that case, is a nap helpful? There is a lot of literature that suggests that short naps in the middle of the day, close to your circadian dip, which is usually somewhere around noon to 2 p.m., depending on your rhythm, is actually beneficial. It breaks up the routine of the day. It gives you a rejuvenation to go on to the end of the night. And if you start dreaming during a nap, it has gone too far. Typically, a nap lasts at its best between 20 to 30 minutes to give the most effect. In general, remember that sleep is as important for anyone as wakefulness. It is another feature of being a human, particularly in patients with epilepsy. It goes a long way to helping with quality of life and reducing seizure frequency. Thank you for listening to me.